Thank you for that very kind introduction, Robert. Colleagues and friends, it's an honor to be invited to speak with you today. Both colleagues here in Vilnius and many colleagues around the world as well online. So greetings from Vilnius. I would like to offer a message of support for everyone who is committed to better mental health, and especially colleagues involved in conflict. I would like to, in particular, to convey a message of congratulations to the Ministry of Health here in Lithuania, who have recently committed to a long-term anti-stigma program, which will put them at the forefront in Europe, indeed, at the forefront of anti-stigma work around the world. I'd also like to add a special note of appreciation to Charlene Sunkel. For over the last 2 years, she and I have been working hard on a special report about reducing stigma. This will be published in Geneva at the World Health Organization on the 10th of October this year, called the Lancet Commission on Ending Stigma and Discrimination in Mental Health. My topic now, however, is on COVID and the interrelationships between COVID and mental health. And I want to briefly indicate what we know in 4 key areas. The first is about the mental health impacts of COVID on the general population. Second, about the impacts on people with pre-existing forms of mental health conditions. Third, the impacts on people providing essential services in our communities and in our societies. And fourth, the mental health implications for people who are or who have been infected by COVID or corona. First of all, what's been the impact, the difference, the effect on all of us, all of our populations? We have now to distinguish between, if you like, year 1, year 2, year 3. The impact of COVID is changing over time, and I will bring you good news and I will bring you bad news. In the first year, there were expected but still high impact consequences. We saw levels of anxiety, uncertainty, stockpiling, mass shopping behavior. We saw people affected by trauma and loss, some people multiply affected by multiple losses at different stages of the pandemic. We saw the effects of being in lockdown, being in quarantine, for people of all ages, whether it be a lonely person, of an older adult, or a child trying to do home education. We saw in some subgroups of the population increases in alcohol and substance use. And there was the possibility in the early stages that especially the economic impacts may cause a rise in suicide. We can see here in the early stages, this is research essentially in 2020 to begin with, that in many groups, the rates of anxiety and depression doubled or nearly doubled. And there were some groups in our societies especially hard hit. We can see the young, especially young women, the rates of increase were higher, especially young women who are lone parents, especially young women with several children or caregiving duties. We saw that the mental health of students was especially hard hit. Where I work at King's College London, we have students coming from around the world for different courses. And many were surprised to arrive in London and then to be confined to a small student bedroom for online teaching, and to have, perhaps throughout the whole of that year for a master's program, no physical contact with their teachers or their fellow students. You can imagine, for some people, the consequences. And also particularly hard hit young children and adolescents, especially young women adolescents. We can see here coverage from my country and from America about some of these issues. And let's look at some of the numbers. This again from the first year, from 2020. And the blue is before COVID, and the red is in the first year. And you can see for children and young people of different ages, approximately 50% increase in the rates here of difficulties, especially anxiety and depression. And greater difficulties in getting help when people were in lockdown. And across the range of young people studies, and I'm going to give you summaries from reviews from across the world, it was clear that wherever this was studied, there was a higher adverse impact, especially on adolescents. And also, for many studies, deterioration in the use of alcohol and drugs. And within the adolescent group, some subgroups even more fiercely affected. People who had little social support, maybe because they were alone, or maybe they were living with people with whom they were not supportive and communicating relationships. People who'd been locked down for a long time, what we in my country call people who are extremely clinically vulnerable, people with a pre-existing severe physical condition, for example. And also those for whom patterns of parent and child interaction were the weakest. These were the subgroups most hard hit. Certainly in 2020, I expected that we would see, perhaps with a year, perhaps with 2 years lag, an increase in suicide rates. And I expected this not because of, for example, neuropsychological consequences, or even fatigue or physical disability, but mainly because we know from the period of 2008 to 2010 what happened in that period of economic austerity and recession. And we know that people who were unemployed then, or who went through periods of economic instability and fear of job loss, had higher rates of depression and, in many countries, higher rates of suicide. But the evidence to date, the evidence so far, has not supported this. We can see here, again at an early stage, some findings from a special review published in The Lancet. It included, in this case, only data from high and middle-income countries. As usual, these data are biased. We know, in fact, that 85% of the people in the world live in low and middle-income countries, but these are the data we have here. And they did not find a consistent increase in suicide rates, at least in that first year. Here's a graph. The details don't matter, but essentially, if you look at the vertical line in the center, then countries to the left are showing lower suicide rates. Countries to the right of that vertical line are showing higher suicide rates. And at the bottom, the summary is no overall increase, at least in the first year, of suicide rates where this was measured. Now, we have to be cautious here and track through what's happening in year 2, perhaps year 3, and see whether that changed over time. A word now, not so much about the mental health aspects, but about some of the comorbid mental and physical implications in terms of long COVID. What do I mean by long COVID? People who have symptoms for a prolonged period. And one of the challenges here is we do not yet have an international consensus on defining this condition, in the absence of which it's very difficult to get a grip on the impact of long COVID. So I've just looked at this last week to try and get the latest review of the data. And for physical health problems, this is shocking. You can see here that for some of the earlier stages, very high rates of persistence. And you can see some of the key features of symptoms that most commonly persist. Chest pain, fatigue, breathlessness, sleep problems, cough. And also, just below, but still common on the list, depression, anxiety. You can see here 64% had at least one persisting symptom after being infected over 6 months. 59% had at least one symptom over 1 year. And then some definitions say 3 or 4 symptoms, some say for at least a month, and 6 months, and 12 months. But it's really hard to understand this while we don't have clear-cut, internationally agreed definitions. A recent review at the bottom, you can see by Chen, has tried to put all of this information together and says that global estimates of prevalence of long COVID, 43% of those infected have long-term physical problems. And at that point, this is a few months ago now, 470 million people in the world estimated to have been infected, 200 million people in the world estimated to have ongoing aspects of long COVID. But it's not just those features I mentioned a moment ago. This is a noxious, a terrible virus which affects essentially every system in the body. And over 100 symptoms have been described as aspects of these ongoing disabilities and illnesses. We also know it's not just the symptoms, but quality of life, as you would expect, is badly affected by these long COVID. And I found this a troubling finding, is that the onset of long COVID is not necessarily associated with having had a severe infection of COVID. But generally one can say that those groups in the population worst affected by long COVID are older people, men, and people living in high-income countries where this has been measured. And in general, long COVID is worst for those people who have had more severe acute infections. Secondly then, what about the impacts, the mental health impacts of COVID on people who had mental health conditions before the pandemic began? Well, in fact, the first few months, let alone the first few years, there were many. In my own hospital, 3 of our wards, our mental health wards, were closed to allow our general physical hospital next door to have more space to treat more patients. We know that in general, people with mental health conditions are more likely to have physical health conditions than the general population. This comorbidity, this co-occurrence is really very common. And we also know that there are factors for people, at least in hospital care, such as being very closely put together, perhaps in poorly ventilated circumstances. The same applies to care homes and residential homes, which actually increase the risk of infection. In my country, we had the disgraceful development whereby people from hospital were moved quickly out into residential care homes to free hospital beds without being tested, and in fact themselves became vectors for infection into those homes. And we know that in some countries there has been neglect of essential services within mental health care, such as interruption of supply of medication, because the focus for much of 2020 was simply upon COVID and Corona. One of the implications has been studies looking at the death rates from COVID among people with pre-existing mental health conditions and recent onset of mental health conditions. And you can see here some of the figures are staggering, up to 7 times higher mortality rates than the general population for people with some types of mental health condition. And you can see here that some groups here, up to 60% increase for people with severe mental illness and so on. And you can see that the rates vary, but by and large, substantial increases in the risk, not just of infection or symptoms or disability, but the risk of death. One group that I think hasn't been discussed nearly enough are people with intellectual disabilities. Sometimes we say people with learning disabilities. And it took a long time, almost a year, before data emerged about this group. Partly again, because of concurrent physical conditions, partly again, because of conjugate or residential shared housing. And here are some data from my own country. In blue, we can see the general population. In red, these are people with intellectual disabilities, and then you can see for different age groups. And you can see large, or even for older people, huge increases in the death rates from COVID among people with intellectual disabilities. Third, I would like to say something about the impact on people working in essential services. What do I mean? Well, not just doctors and nurses, but people in logistics, transport, milk delivery, bread delivery, train drivers, bus drivers, many of whom are working in confined spaces, shared with others, at particular risk of infection. Certainly in the first year, in my country, forget about days off, forget about holidays, people coming in day after day after day, working in protective equipment, wearing masks, having itches and rashes by wearing these masks all the time. My son's a physiotherapist. He was then immediately deployed onto an intensive care unit, dealing with multiple patients dying and their bereaved families. Extraordinarily difficult work. And also a problem sometimes called moral hazard. One bed with a ventilator is available, and on the respiratory ward are 3 desperately sick people with low oxygen saturation. Who chooses who will get that ventilator? On what basis can that choice be made? And many healthcare staff will say, I've never had training, I have no experience, this isn't my competence, but somebody has to decide, and I feel terrible for the patients I didn't choose for that chance of life and survival. And these pressures, even more intense in low LMIC, low and middle income countries, where resources are so much fewer. Many journals and newspapers carried stories over this period of the impact of doctors and nurses. Indeed, for some healthcare practitioners who took their own life after these, for some people, intolerable pressures. I would come home with tears in my eyes, people working long, long hours, coming home, not even seeing their children before they went to bed, hardly eating all day, having to get up early the next day and start all over again. And during the latter part, particularly of 2020, studies were coming out about the mental health impacts of these pressures. This is one study, nearly half of NHS critical care, this means intensive care staff, report post-traumatic stress disorder, depression or anxiety. And again, in the first wave, when we had high rates of hospitalization, high rates of respiratory distress, high rates of intensive care, a study in my country looked at the rates of anxiety, depression, post-traumatic stress disorder, or any combination. And you can see the results here. For the top, which I can just read here, anxiety, just about half of all staff. For depression, about the same. And these weren't intensive care, these were general staff working in our health service. For post-traumatic stress disorder, about a quarter, and for any of these, 58%. The majority of staff had a diagnosable mental health problem during that first year because of the understandable reactions of the pressures under which they were working and committing to public service and public life. In how many of our countries was this recognized, and in how many of our countries was this responded to and has been responded to in 2020, in 2021, or in 2022? Now, here's a study then, an overview looking at the impact on healthcare assistance, finding essentially the same results from many, many countries around the world. Wherever this has been studied, there has been an adverse mental health impact from those who are giving their time, their commitment, their energy, their expertise in the service of others in our health services, in our health systems. And here's one example led by Professor Irina Pinchuk, colleagues in the Ukraine. And this also found very similar findings. This published just a few weeks ago, you can see in this journal, finding that healthcare professionals who care for COVID-19 patients have an increased risk of mental health problems and need particular support. Many of us here will be people working in these essential services. Many of us here, physically here and also online, have particular need of particular support. Fourth, I'd like to say a little bit about the impact of people infected by COVID in terms of later mental health difficulties. Again, I'll start with the early aspects, particularly in 2020, and the very fact, not just the infection, but the quarantine, the lockdown arrangements contributed to this increase in anxiety and depression, but also other types of mental health problems. For example, an increase in obsessive compulsive disorder. We also know that complex types of neuropsychiatric and neuropsychological problems occurred, for example, delirium and other unusual forms of symptoms. Often at the time of greatest need, when infected or just after infected, was the time of least support. We were told not to share a room, perhaps not even to share an apartment or a house with someone affected, leaving a plate of food by the door and so on, not to share a bathroom if that is possible. So just when you need the most help is just when you won't get it. So it's no surprise so many people had these mental health difficulties. And then we had what for me was a surprising and a very disappointing development, namely the development of stigma against people with COVID, or indeed anyone thought to have any connection with COVID. So we can see here about some of the implications. Nearly 1 in 5 COVID patients later diagnosed with a mental health problem. And many of these studies show a quarter, maybe 20% of people with COVID infection shortly after developed a mental health difficulty. You can see a study from America with essentially similar findings. And in particular, there were mental health adverse consequences for people who'd been through intensive care or ventilation experiences. Here's one study, and on the left are the rates of mental illness among people who were not in receiving intensive care, and then degrees of respiratory and ventilatory support, and on the right, people who'd been ventilated at that time. You can see much higher rates, in this case, of PTSD following that experience. So for those of you wanting to think about a summary of where we are, well, this is quite a good paper here. And you can see that anxiety and depression and distress have all become worse in our populations, now assessed really over the first and the second years. But so far, we have not seen increases in suicide rates or satisfaction or, on balance, loneliness. I mentioned a moment ago about stigma, not in this case, stigma against people with mental health conditions, but stigma against people in any way associated with COVID or corona. Sometimes by prejudicial national statements about the origin, something like the Spanish flu idea. Sometimes because of the name, we can think now of this also applying to monkeypox, a really grossly stigmatizing term. And this is a woman in Spain saying, non tengo corona. So she's saying, I do not have coronavirus, because she's of Chinese origin, and she's being abused in public in the first year because of public discrimination of people thought to be the origin or the point of origin of COVID. Now, we've also looked in a paper recently about thinking how to reduce the stigma against people with COVID. And this paper essentially says we have to pay close attention to the public messaging in very consistent and positive terms. And also, what the WHO does encourage is giving neutral names for these viruses to try and take away blaming any subgroup within society, which has sometimes led to attacks upon individuals or groups, grossly pejorative reactions. So just before I finish, a word about whether all of this has had an impact on mental health services, on mental health care? And certainly in the first year, the answer was yes, and the impact was negative. This is a rapid appraisal by the World Health Organization, carried out in the first 3 to 6 months, and most of the countries are part of the World Health Organization, part of the United Nations responded. Nearly all said that their services had deteriorated in that first year because resources were diverted and taken away from mental health care to physical care, especially to COVID. And we're actually tracking now in another study, including with Professor Irina Pinchuk in Ukraine, whether that's still the case, and if we see longer-term damage to mental health care. The WHO leaves us with several key messages, which unfortunately include some abbreviations here for mental health and psychosocial support, which should be an integral part, not an add-on or a forgotten part, but an integral part of planning to support the recovery of people affected by COVID. That this should be implemented in general care, integrated into the interventions, for example, in primary care, and we may be learning some interesting positive elements. For example, 2.5 years ago, I could not offer patients a consultation by video link. I'd never heard of Zoom. Most of the people I see now, the patients I try to help, either by phone or by Zoom, sometimes by Microsoft Teams. And this has its pluses and minuses. This is not the time to go into that. But there are some advantages to having the opportunity for remote consulting and telehealth opportunities. And in terms of the bigger picture, I think we have some opportunities now, as we heard from the Minister a moment ago, about not just building what we had before, but deliberately reconsidering the reform, the renovation, the improvement of mental health care, and building back better. And that includes healthcare in schools, in the workplace, in primary care, and in our communities. Now, I finish with a little bit of good news. The news from long COVID surprised me and wasn't good. But the information published this year about the second year of follow-up for people with mental health care is actually improving and is reasonably good. More recent studies have found that the initial rates, the increased rates of anxiety and depression have not, at the population level, have not persisted over time. And in many cases, the rates of anxiety and depression have gotten back down to their pre-COVID levels. So maybe 15, 18, 20% if you combine anxiety and depression. So that's good. What's not good is that we're still, in European countries, we're still only treating a quarter of people with those conditions, but at least that bulge, that surge, for the moment, has subsided. And we very much hope that we will not see further peaks of COVID or other pathogens coming back to haunt and destroy us in the future. So to summarize, it is an honor for me to speak to all of us here and in our digital wider global community, especially colleagues here from Ukraine and from Belarus as well. I wanted to say something about the impact on all our societies, about people who had pre-existing mental illness before COVID or Corona, the impacts, very severe impacts on people who are in caring positions and professions, and upon people infected by COVID. Let us hope that we will live soon in better times. Thank you very much for your attention.